And Dr. Johnston is transplant nephrologist at VGH and clinical assistant professor of medicine.
Thanks, Maureen.
Do we need on?
I don't know. They'll have the slides. Oh, here we go. It's up there, but we don't have anything here.
Oh, there you go. Yeah, you're here.
Okay.
Yeah.
Good morning, everyone. So there's going to be a lot of repetition because we talked a lot about transplant first, etc. this morning. And I'm going to give you some of the reasons why preemptive transplants should be first. First of all, my main conflict is that I make my money from transplant as well. And I'm also have a very close interest in preemptive transplant. I've done some research on this several years ago as well, which I'll talk about a little bit later. But I feel it's a very important issue, and I'm so happy that we're talking about this predominantly today, because it will make a huge difference in people's lives and their survival. And I'm going to go in detail why that is so here. So the mantra, as we've talked about already, has been PD first, fistula first, and by the end of this talk, I hope I'll convince you that it's going to be transplant first, and that we can, from now on, hopefully, if the patients are appropriate, try and break down the barriers that we're having and that Mike has brought up, and try and get our preemptive transplant rates even higher than they are now. So the main objective of my talk is to highlight all the benefits of preemptive transplant, and also to discuss a little bit about how we're doing with preemptive transplant rates here in BC, nationally and internationally, and also to try and see where the barriers are and break them down, and then to try and figure out if there's particular methods that we can use in order to break down some of these barriers. So if you think of the life cycle of CKD, there's numerous transitions that we know. So starting here, where the person is initially diagnosed with chronic kidney disease, it progresses, and it then gets to a stage where a decision needs to be made about renal replacement therapy. So for preemptive transplantation, as we all know, it's transplantation before the need to go on dialysis. So this is what we're going to be highlighting. And the benefits of this, so we hear that there's huge benefits, and what are they? So there's an established survival benefit, patient survival. People live longer if they get a preemptive transplant, and that's the bottom line. Also, there's a lot of quality of life benefits for various age groups. Again, I'll go into that too. And economic benefits. Here in Canada, we're spoiled because our health system doesn't emphasize for individuals the expense of all of these modalities, but in places where there is a private health system, then that can be a huge influence. The expense of lifetime dialysis versus lifetime transplant, etc. And on an economy, that has a huge influence on healthcare expenditure. And then overall health of the patient, there's also benefits. So looking at survival first, if somebody can avoid dialysis, they live longer, and that's the bottom line. So here you can see, this was a study done in the 90s, looking at the benefits of patient survival after transplant and the duration of their dialysis before they got transplanted. So here in this column is patients who got transplant before they needed to go on dialysis, and you can see that their survival is the highest. And as the longer you're on dialysis, the lower your survival. And if you look at it in a different way, you can see here this top line survival curve here is patients who got transplanted preemptively, and they have the highest survival even way out from transplant. So and here, this is patients who got transplanted 1 to 2 years after of dialysis, and these are people who have been longer on dialysis prior to transplant, over 3 years. So there is a definite benefit, and that benefit is sustained post-transplantation. The benefit is patient survival. So if you look at overall graft loss, so when you look at overall graft loss, that includes patients who died with a functioning graft. There is a benefit from preemptive transplant over time after transplant if they haven't had dialysis prior to transplant. But if you look at graft loss and you remove patients who died with a functioning graft, there isn't a particular benefit from preemptive transplant compared to people who are on dialysis. So the main benefit from preemptive transplantation is patient survival. Now, an interesting study that was done several years after that previous study, it was actually done in deceased donor transplants, but it kind of highlights the benefits of a shorter duration of dialysis pre-transplant. It looked retrospectively at US data, and it looked at pairs of deceased kidneys, one of which went to a patient who had less than 6 months of dialysis, and the other went to a patient who had greater than 24 months of dialysis prior to transplant. And it looked at their survival after transplant. So at 5 and 10 years, there was a significantly higher survival in patients who had the lower amount of hemodialysis, so less than 3 months, than those who had greater than 24. And this was a very good experiment because you're looking at kidneys from the same donor, but they had different hemodialysis durations and looking at their outcome. Then because of this, because of all these studies looking at dialysis duration, I was wondering if the same effect happened for repeat transplant. All these studies are done in people who've had their first transplant. But now, more and more, we're seeing people who have failed transplants. And does the survival benefit of preemptive transplant, does that carry over to repeat transplant? So a couple of years ago, we did a study here looking again at US retrospective data to see if the duration of dialysis between failure of your first transplant and getting a repeat transplant, if that had an influence on survival. And it does. It has a very similar effect to that of the first, if you were getting your first kidney transplant. Here, you can see the survival curve of a preemptive repeat transplant compared to patients who were not preemptive, and there is a survival benefit. And this is all-cause graft loss. Again, similar to the studies looking at first kidney transplant, the survival benefit was for patient survival rather than for graft survival when you took out patients who died. It was interesting also that the duration of graft function of the first transplant also influenced their survival. And also, if you look, this is an interesting slide. So if you look at the duration of dialysis between the first and second transplant, it had an incremental increased risk of patient death. So dialysis greater than 5 years after transplant failure to repeat transplant, your risk of death was much higher than if you had only a short period of dialysis after your failure. So survival is very strong for preemptive transplant. How about quality of life? Well, numerous studies have been done looking at quality of life in this particular group of patients. Quality of life is improved in most age groups. The particularly strong benefit is seen in adolescents who get a preemptive transplant. And it kind of makes sense in a way because these are patients who are going through a lot of turmoil psychologically in adolescence as well. So if they can avoid transitions as much as possible, then that has a big influence on their quality of life. So the next slide looks at these transitions. So if you look here, this is functional status, which is a combination of work status, family life, mental health, self-care. And here is the disease course. So we're looking at two different patients here. In red is somebody who's got a preemptive transplant. In blue, you see somebody who went on dialysis first and then got a preemptive transplant. But you can see that each transition, here is a patient who has CKD. And then suddenly, they reach end stage and they receive a preemptive transplant, so they have a reduction in the quality of life initially because of surgery, recovery, etc. And then they go back to a baseline, and that baseline continues. But if somebody goes, their first renal replacement therapy is other than a transplant, then they have that decline in function. It's actually more significant than if they're getting their transplant, and they go back to a baseline. But then, of course, they receive a transplant then, so they have a further transition and a decline in their functional status for a period of time. And then they go back to a baseline. The baseline is actually higher than the baseline they would be if they were on dialysis. But each of these transitions causes a change in the quality of life. So if we can reduce the transitions for these people, that has a huge impact. This slide was part of a U.S. National Kidney Foundation and KDOQI conference that happened in about 2007, which was looking at the whole concept of kidney transplantation first, and the benefits, the barriers, the ways that we can change it. So even at that stage, people were thinking about this as well to try and figure out ways that we can promote kidney first. And this particular study was part of that because it was divided up into various work groups. So there's still ongoing study in quality of life. For example, this is a French study that's ongoing at the moment, and it's looking at looking at the quality of life in patients who got a transplant preemptively versus those who were on dialysis for less than 36 months before getting a transplant. The quality of life domain scores are done at various time points while they're waiting, after transplant, and ongoing, and then the comparisons will be done afterwards. But we don't have any results on this yet. It's still recruiting. But it's interesting to know that there's still those studies happening. A lot of economic benefits. So again, this is from that consensus conference that happened in 2007. Here, we don't really have a lot of Canadian costs because in the US, there have a lot of data on these costs because of the payment system there. It's hard to see this, but if you look, this compares a patient who was on dialysis first and then received a transplant versus somebody who got a preemptive transplant. Here on the y-axis is the expenditure. So you can see that when somebody is CKD, the expenditure is not that high. But when they initiate dialysis, the cost is huge, and that is because of PD access, fistulas, hospital admissions, et cetera, at the time of starting dialysis and dialysis itself. So the expenditure then, once they were established on dialysis, the expenditure is ongoingly the same until they have another transition. So here is the time of transplant. So at the time of transplant, there is extra costs, and particularly in the first year where there may be hospital admissions, there may be drug costs, etc. And then the maintenance after transplant then is much, much lower than it would be for dialysis. In fact, after 2 years of initial renal replacement therapy, whether that's whether it's hemo or PD, there's thought to be at least 35% reduction in expenditure if somebody gets a preemptive transplant versus if they're on dialysis first and then gets a transplant. Here you can see the expenditure with somebody who gets a preemptive transplant and doesn't go through the dialysis modality, and you can see that much sooner they get to a lower expenditure rate than they would if they transitioned. Employment is a big thing too. So our patients we see, I know a lot of patients we see are older, but you know, there are people who are working age. So it's been shown numerous times that if people get a preemptive transplant, they're back to work much quicker. More than in one study showed that people return to work greater than 50% were preemptive, but by the first, if they were 1 year on dialysis, only 24% returned to work after transplantation. That has a huge impact economically. Also disability, because as we know, a lot of patients who are on dialysis are on disability. And this has a huge impact on return to work rates the longer they're on disability, as well as family life, et cetera, as well, and family dynamics. Other economical things that we should think of are the access and redoing access, et cetera, and all the costs incurred with that, as well as infections, et cetera, extra hospitalizations incurred with renal replacement therapy other than transplantation. Transplantation, we do have hospitalization rates as well, but much less with preemptive because they're so much healthier going into transplant. Overall health is also impacted, and we look after adults mostly, but in children, overall health is hugely impacted with preemptive transplant because their growth rate is much better. They don't have the hospitalizations, and from a transplant perspective, there's been shown to be reduced rejection rates, fewer sensitization events. With preemptive transplant, also reduced cardiac risk exposure because of or because of reduction in or absence of dialysis, and overall hospitalization rates. But in a lot of these studies, it's, everything's very positive with preemptive, but we have to keep in mind some of the biases that may be encountered in some of these studies. So one of them is lead time bias. So with that, I mean that the intervention starts much earlier in the preemptive group than which is transplantation, than it would in the dialysis group, because transplantation happens later. So survival rates are longer. Recipient selection biases can also be something that we should keep in mind as well, because people who get preemptive transplant may be the healthy people who we expedite for transplant really quickly, and of course they will do better. And residual kidney function as well. Some people say, well, that might be an advantage, but actually studies have shown, one of them by Doris Segaf, who we've heard a lot about this morning, but a couple of years ago, he did look at that and looked at, over time in the US, at what GFR people have got their preemptive transplant. In the 90s, people got their preemptive transplant on average at a GFR of 9. And then later in the 2000s, it was higher. It was like between 13 and 15, around 13. And then he looked at, did that make any difference on survival of those patients? And it didn't. So residual renal, the timing of preemptive transplant, and that's always kind of, something that we're back and forth with nephrologists around the province about it. When should we do this? But there's not a magic number. So it's a combination of things. It's a combination of how the patient is feeling and how their numbers are. But we want to try and do the surgery. If they have a living donor, we want to try and do the surgery before they start getting sick and before there's a last-minute emergency need to go on dialysis. So it's, sometimes that can be at a higher GFR than the next person. So there isn't a magic number that we say, yes, at that point we do it, and if they're not at that, we don't do it. So that's something some people ask me. So we know it's good. So preemptive transplant should be the way everyone gets transplanted, but that always doesn't happen. But how are we doing? Like, how are people doing in one country versus another? How are we doing here in BC? So internationally, in the US, there's a lot of data on preemptive transplant, and looking at the time period between 2003 and 2012, 17% of end-stage renal patients had a preemptive transplant. Now, in the US, that's kind of different than here, because in the US, people can be preemptively waitlisted on the deceased donor waiting list before they go on dialysis, which is different from here. So those numbers don't really, it can't be really generalized to Canada. But the numbers that can are the number of living donor kidney transplants who got preemptive transplants. And in that period of time, it was 31%. And with time, so initially the number of living donor transplants who got preemptive transplant was 23%, and then with time it increased, which you'd kind of expect. But if you look here at the data, an interesting thing is that these are the patients who didn't get a preemptive, the patients who didn't get a preemptive transplant. And if you look here at the living donor kidney transplant recipients, you see that 30% got a living donor transplant within 1 year of starting dialysis. So this is the group that we all need to kind of focus on. Why is that? There's a lot of questions, and that wasn't teased out in this study, why that particularly happened. In Canada, we saw some of the data already in Canada, and this is kind of looked at in a different way. So here are the patients who reach end stage each year between 2005 and 2014. And the majority of people go on hemodialysis. But for preemptive transplant, 3% of all patients who reach end stage per year, on average, get a preemptive transplant. And that's really low. But that's an average across the country. That's the average across the country. What happens, depending on age? Well, the good news is that more young people between 0 and 19 are getting preemptive transplant. You can see here in 2014, these are just numbers rather than rates, but you can see that over time the numbers are increasing. But for all other age groups, the numbers are pretty static. BC are doing great. So I don't want everyone to think that we're doing terrible. We're actually doing the best in the whole country. These are the numbers from 2014. And in patients who reached end stage in 2014 in BC, 4.9% got a preemptive transplant. And that's the best in the country. The average being 2, 3, 4 here. But that was very good. And one of the reasons for that is because we do a lot of living donor transplants, and we heard this already earlier today. And here is BC here, and as you can see, in blue here is living donor transplant, and in red is deceased donor transplant. And you can see that we do a lot more living donor transplants than the majority of the other provinces. Looking more closely at BC data, we saw this before. In 2005, we had one of the highest transplant rates ever. The interesting thing is that there wasn't a big decline in deceased donor transplants, or in living donor transplants when our deceased donor transplant rate increased, which is reassuring for us. And that's why our overall number then increased. And the rates per million are much better than the Canadian average. So you can see here the Canadian average, this is old data, but it's about 12 donors per million population. This is 2014, but 2015 it was 24 donors per million population here in BC, and that's fantastic. You can see this shows you the type of living donors that happened. So biologically unrelated is getting a little bit more common now and biologically related is kind of staying static. But there has been a big increase in our paired donation living, and that has contributed a lot to our living donor rates. In 2015, if you remember in the US, the number of living donor transplants that were done preemptively was 31%. In 2015 here in BC, 37% of our living donor kidney transplants were preemptive. And that's very good. That's really, really good. But there's always room for improvement. It's still only 37%, so there is room for improvement. So this is an interesting slide because this is the recent data from a BC Transplant. And it's looking at a patient's status after 5 years of being on dialysis in BC. And here in the darker color are the people who are still waiting. This is pretty old data, but thankfully that level of people still waiting is reducing, and that's even further reduced now. In purple here are patients who got a living donor transplant. So these are patients who have been within 5 years of transplant, or within 5 years of end stage, have got a living donor transplant. These here are the patients who got deceased donor transplants, removed, died. But this purple group we want to try and get that into the preemptive stage rather than being on dialysis in the first place. And if you look at it in a slightly different way, so the median time or the median number of months of a living donor transplant who get dialysis exposure is about 8 months. So what happens in those 8 months that they don't get a preemptive transplant? So that's where we need to put our work into. And that's only a short period of time. So there must be barriers that we need to break down that we can prevent that from happening. This is another interesting slide. So this is more recent data. So if you look here at the time to living donor transplant in BC, so here in the dark color is preemptive transplant. And as I said, we're doing really well here in BC compared to other provinces. But if you look at this I don't know what color that is, green, there's about 20% of patients who get a living donor transplant in BC who are on dialysis for less than a year. So again, like in the previous slides, this is the group that we really need to focus on, because these may be people who have donors going into transplant and they're just not ready in time. This is what we need to concentrate on. So despite the benefits of preemptive transplant, it's concerning that the majority of the recipients of living donor transplant aren't getting their transplant before they go on dialysis. And these are the numbers that we quoted earlier. So let's look at the potential barriers and challenges that we might be facing. So before I go into any of this, and the barriers, we're doing a very good job here in BC, and I'm not pointing fingers at anything with the challenges we face, because these are challenges that are faced internationally for preemptive transplant. We're actually overcoming a lot of the barriers that other groups are still facing. And as Monica talked about earlier, our educational program for KCC is actually very much advanced compared to other centres. So we've actually advanced much more here, but there's still barriers and there's still work that we can do. So I'm just going to highlight some of these barriers. So I'm going to divide it up into different factors. So we look first at the patient factors. And this sometimes can be a huge barrier because you have to try and crack the nut in order for them to be able to realize the benefits. A lot of patients, and we all have come across this, they are very uncomfortable about asking somebody for a kidney. And this is all about education. And it's all about, as Monica was saying, asking the questions that the patient wants to ask, or answering the questions the patient wants to ask, and giving them guidance. And certainly in the transplant centres, we do a lot of outreach with patients. Sometimes when we see patients, you know, and we mention living donation, the first thing they say is, no, I'm not letting anybody give me a kidney. I'm going to hurt them. So then you have to go back to the very beginning and explain all about the benefits and how donation happens and the risks involved in donation. And the alternative is to cease donation and their potential waiting time on dialysis. So that's a big barrier, and that can take time. And as Monica said, it can take many, many visits for them to kind of eventually come around and for the education to sink in. Sometimes patients can receive the information late in an advanced stage of CKD, or even when they're on dialysis. Thankfully, that doesn't happen as much here in BC because we have a lot of safeguards, and there's a lot of stages along the way where education happens. But that can be a big problem in other centres. Psychological barriers as well is a huge thing. I mean, these are people who are facing end-stage renal disease. So you're talking about, even if you talk about any modality, we've all had it. These people who you're trying to prepare for access for dialysis, and they say yes, and it never happens, and they end up with temporary access and an emergency admission, etc. The same is true for transplant. They are in denial of having end-stage renal disease. They don't think it's ever going to happen, that they're going to need replacement. And time ticks, and their renal function goes down, and it reaches a stage where they're not prepared for preemptive transplant. So that's another thing that, again, it's multiple discussions with the patient about what they're thinking and what are their obstacles in making decisions. Education, we talked a lot about already. And other patient factors can be very practical things, like maybe the patient is highly sensitized and is going to be very difficult to match. So it may be next to impossible for them to get a preemptive transplant. Even though they may have a donor, it might not be a compatible donor. They might need to go in paired exchange. There might be a long process involved. But you know, that's a small percentage of patients, but at the same time, that can be a patient factor that may be attributing to some of those issues we saw before in that 20% of patients who were on dialysis for a little while before they get their living donor transplant. There's factors as well with KCC and the healthcare providers, with education, misconceptions that patients may have, but I think we have broken down a lot of those barriers with the education program we have in KCC here in BC now, which is advanced a lot compared to other centres, even across the country. Again, receiving information at an advanced stage and too late before they start dialysis, which may result in late referral to the transplant centre. In the past, here in BC, you know, we probably haven't promoted preemptive transplant enough. And patients have been referred for transplant assessment if they already knew that they had a living donor, or if they were almost on dialysis or ready to start dialysis. So we want to change that mantra. We want people to be referred to us at an early stage in order for us to be able to prepare them for preemptive transplant, rather than their GFR is 11 and they're just about to start and we know we're not going to have enough time to work up a donor for them. So even if they don't have a donor and their GFR is falling, then we should see them, because we can be another discussion from KCC. We can be the other people discussing the whole benefits as well. And the more that's repeated to a patient, the better they can understand the benefits, and hopefully we can progress with their transplant. This didn't turn out too good. But what I'm trying to say here is a better communication between healthcare providers, transplant centre, and vice versa. And I think that's improving, and particularly with a promise system that is much improved now, where we can see the status of our patient on promise without having to make calls to the transplant centre to say, where is the patient at? Is their donor ready, etc. And even next week, we have a new module on promise looking at the pre-assessment, which is a pre-assessment module, which again will have everything on one page. So it's actually going to be really good. And it's launching next week, Raoul? Tuesday, yeah. Then the transplant centre, again, this doesn't turn out good. There can be delays in recipient and donor assessments, and this is frustrating for both us and for the healthcare providers sending them in as well. Recipients might not do their testing; they miss their appointments to get cardiac testing done, etc. And then, of course, we can't tell the recipient where the donor's at because of confidentiality, and that's always a conflict with the transplant centres, because the recipient says, oh, my donor said they're ready to go, what's happening? And the donor has no workup done, you know, and we can't tell them that because that's not, we're not allowed to do that. So there's a lot of anxiety between recipient. So we always tell the recipient to talk to the donor, find out where they're at, and that will help. For the donor assessment, even though we're trying to get this done preemptively, we cannot control the donor's speed of getting their workup done. It's their priority, as to how fast they're going to get this done. We can tell them, you know, that the recipient will need to start dialysis soon, and that's why they're getting the transplant. But it's up to them how quickly they're going to go through their workup. So that sometimes can be one of the reasons why people don't get a preemptive transplant, because we're depending on the donor workup, or we're depending on the recipient workup to be completed on time. We certainly try our best to get everything done, but there's a lot of balls in the air to try and get everything. And this is something that you were talking about already, Mike, because it's a very complex thing to get the timing just perfect. Then also there can be delays in kidney product exchange. When I mean delays, there can be delays in matching. So as I mentioned earlier, somebody might be highly sensitized, or they may be difficult to match. Their particular HLA might be difficult to match, and they may go through several cycles of KPD before they're matched. And at that stage, they're on dialysis. So that can be a factor as well. Patient access to transplant centres should not be a problem here in BC. We have the infrastructure in place that should not make that a problem. When they come down to the transplant centre from a long way, we would always organise dialysis, etc., for them, and always organise their whole transplant workup to happen within 24 hours or 2 days, so that they wouldn't have to come over and back to the transplant centre. And then again, communication again. And these are all factors that were brought up at that 2007 consensus conference. But I think a lot of these have been looked into here in BC, and we're improving our flow in order to cut back on these factors. So with that then, how do we increase preemptive transplant? Well, these are the recommendations from that conference. So promoting patient education at the CKD stage 3 level regarding transplantation as the primary option. Promoting early referral to the transplant center. So at CKD stage 4, or depending on the rate of decline. Then promoting the knowledge in relation to living kidney donor transplantation to patients and CKD and their providers, which this is all part of it today, and improving efficiencies, both at the transplant center, communication, and with the referring physician, and at that stage in the US, the preemptive living donor kidney transplant rate was 26%, and they wanted to get it up to 50%. And I think at our level at the moment, it's an extra 12% to 13%. That's very achievable here in BC. And it could be even higher here in BC because of our living donor transplant rates. And it'd be nice if we could get incentives for people to try and increase preemptive transplant rates. So with incentives, I mean, if we had preemptive rate per nephrologist, or referral rate per nephrologist for the transplant centres, if we look at your preemptive transplant rate, or if we look at the duration of assessments, or average duration of assessments for these patients, etc. If we have some kind of measure that we can see how good we're doing, and also looking at our transplant assessment, and we've talked about this at various talks before, where we look at various stages in the assessment to see is there any barriers to various parts of our assessment that we can make quicker. And then in addition to that, I think it's important, and we haven't done this in BC yet, but it's something that we definitely should do, is in that 20% group of patients who are on dialysis less than a year before they get a transplant, we should tease that out a bit more. And we have the capacity to do that here in BC, to look at what was the reasons that these patients didn't get a preemptive transplant. Was it the referral time? Was it highly sensitized? Was it because they were delayed in KPD? Or what is it? Because these are the group of patients that we might be able to get into that preemptive group. Communication and the speed, we've talked about this before. So in summary then, preemptive transplant is good. It has a lot of benefits that we talked about, so patient survival, a lot of economic benefits, quality of life, health in general, over dialysis. And we here in BC have a really good rate, one of the best in the country, but we can do better. So 37% of our living donor transplants last year were preemptive. We can definitely get to 50% if we figure out what those barriers are, and if we optimize all the barriers we talked about today. Early referral is key, so I think we need to change our mindset into transplant referral. Rather than somebody who's ready to go on dialysis or who has a donor, we should refer earlier in order to see if we can find living donors for the patients, and if we can see if they do have a donor, can we get this done preemptively? And more detailed analysis. So that's what I just said there. So any questions? Thanks for your attention. Any questions from the other sides? Oh, Johnston, sorry.
So what are you saying? So part of one of our barriers is the cardiologist is not going to do any angiography when their GFR is 15, you know. And so
I know.
What are you saying to them? So they're saying, well, call me back once they're on dialysis. And are we accepting that, or are we saying, no, it's still better for them to go for it and have their angiogram done if there's potential for...
So it depends on the reason for the angiogram, of course. But if they are, you know, usually they would be referred probably by the time, you know, it's not necessary that they have the angiogram before they're referred to us. So if there is something there that we think, okay, they have a donor, their GFR is 15, and there is something that they need an angiogram, then we would have to talk to the patient about that, about, you know, if we have all this set up and we do the angio and it's okay, then, you know, can we actually work with this? So there's kind of ways around it, but then of course it depends on, you know, the degree of suspicion for doing an angiogram, because it might not necessarily, it might be just low suspicion and we're doing an angiogram just to be safe, or if there's a high suspicion and then they probably do need an angiogram. So it all depends. But I think, you know, it may need a second cardiac opinion or something, whether they need it or not, you know. But certainly, you know, I would always think that it's better for the patient as well if they get that information that it's a possibility that they might get preemptive transplant, and if they know the risks, and if they do need an angiogram, then, you know, it's their decision and risk as well, you know. Any other questions? Mike?
So as the doctor for the patient who needs the kidney, my perception is that a lot of the delay often is on the donor side, and the person's either looking for a donor or their donor is not operating in a timely fashion. And so my question is, I know as a transplant center, you know, we don't want to be perceived ethically as kind of trying to get the donor to donate if they don't want to donate, right? It's not okay. But what about donor outreach that's a little more active? Like, is there any role for calling up the donor and saying, you know, giving them some education or asking them where they're at?
Yeah, so that's a very good question. So as part of the donor education, that's one of the things we do tell them, that you know, there is an urgency in doing this. There's a reason that you've been picked as a donor. This person needs a transplant. And hopefully that donor has been in contact with the recipient and they know how they're doing. That's a big motivation. And that's why, you know, a lot of the living donor transplants happen for people who are, you know, quite close, so that they know there's motivation there to move forward. Some donors come forward to us and the recipient hasn't even been seen yet, and that's a problem, because we can't really move forward as the donors workup until we know that the recipient's okay to go. So, but in answer to your question about the donor, we can't put any duress on the donor. We can certainly highlight, you know, that the person is nearing dialysis, and you know, but we can't say you need to hurry up, you know. Sharon. And to add to that again, I mean, sometimes donors progress to this stage, and it's at this stage they get cold feet because the pressure is on them then. And sometimes a delay like that often is an alarm bell to us to say that the donor might not want to go ahead. So that's even more reason why we can't put duress on people, because they have the right to pull out at any stage. You know, people who are have very genuine reasons to be a donor, they usually progress at the steady level all the time. But it's the people who lag at the end, oftentimes we're kind of worried that their motives for donation, they might be starting to get cold feet now. So they might not want to tell us that, but that might be what was happening, because they don't want to say to the recipient, like, I'm not going to give it to you now, you know. So it's sometimes an indirect way of telling us that. Hi. Can more than one person be worked up as a living donor? So the question is, for one recipient. Yes. So the question for the to the other centres is, can more than one donor be worked up for one recipient at one time? The answer is yes. Sometimes recipients, if they're that lucky, and we always tell them how lucky they are if they have several donors, is that they may have a direct donor amongst all of those donors, and that will be the best way of getting a preemptive transplant. There may be people who generally want to give to that donor, to give to that recipient, but they may not be compatible, so you're talking about paired exchange, etc., which in itself is fantastic too. But if we can find somebody who's a direct donor, then a preemptive transplant can happen. And oftentimes, our donor coordinators would tell you that if there's several donors for one recipient and one of those donors are picked, then we often talk to the other donors about potentially giving as an anonymous donor. Because if their motives for donation are that strong, then, and they can see, and they've got the education at that stage, they can see how effective a donation can be, then we've often converted these donors to anonymous donors. So the benefit of working up several donors at the same time is actually very strong. Hi.
With the shift being to refer patients in the early stage 4, does that shift how the workup process goes? Do you delay things versus moving ahead and then having potentially a long wait period until the patient actually gets down to a 9 GFR?
So, I mean, that's a very good question. The initial workup will be the same, because in order for them to be referred, they have to have a certain amount done. Certainly, we need to establish what their pathway would be first. So we'll see them, we'll figure out if there is potential donors. If donors do come up, then if they need anything additional, we'll get that done then. But if it's a case that their GFR is like 18 and they've all the initial workup done and that's fine, and we're looking for a donor, then we probably would wait a little while until we know that they have an established donor, or wait for their GFR to go down a bit more before we do any of the, any of the other additional testing we need to do. If we're not suspecting anything much in that additional testing. If we are, we do that sooner rather than later in case we need to do anything extra. Yeah.